And so right now, I'm looking at you, Immunity Bio, and Patrick Soon-Shiong. There needs to be a companion diagnostic so that people can tell whether these drugs are going to be useful to them without spending huge amounts of money and wasting a large amount of time. After our Anktiva episode, I've been flooded with comments about how it's been proven to work for cancers. That's not the way it actually works, and we should talk about the science. There's both fantastic possibility and real problems. Let's get into them. Hello, and welcome to Elevating Cancer Treatment, where we explain the science and debunk myths to help you navigate your health journey. My background is a little different. Beyond educating about cancer, I'm actually designing new drugs that are defining the future of oncology. This direct, hands-on experience offers me a very different perspective of how these cancer treatments work on the body, interact with the cancer cells, and cause side effects. And these are insights that I'm excited to share with you. If that sounds interesting, make sure to like this video, subscribe to the channel, and hit that notification bell so you never miss an update. And please share it if you find it useful. I'm Dr. Jay Chaplin. An important reminder, I'm a PhD, not an MD. The information in this video is education, and it's not medical advice. Every cancer is unique, and no general information applies to everyone. Please remember that. Always consult with your healthcare provider for guidance on your specific situation. And two quick things. First, as a thank you for being here, I've created a free resource, 10 Things to Elevate Your Chemo Journey, which you can download from the link below. And second, by signing up, you'll also get updates on that innovative cancer treatment I'm working on. I'm confident it represents a significant advancement in immunotherapy. So please take a moment, download your free guide, and join us in shaping the future of cancer treatment. So in the last episode, Immunotherapy Basics, I talked briefly about how immunotherapies work and some of the basic functions of your immune system and how the different cells operate and how the drugs interface with those to make everything better for treating your cancer. So today I really want to dive into something that I've gotten a big earful about of Anktiva, the IL-15 stimulant for NK cells, that it's been proven to work for cancer. That is a drastic, huge, expensive, false hope oversimplification. Anktiva is a fantastic drug. It's got great potential. Do not think that I'm trying to undersell it. And you have to understand what it is, how it works, and what it's good for in order to use it appropriately. And the way it's being talked about to you is a lie. You deserve better. Okay, so in order to talk about Anktiva, I'm also going to compare and contrast immune checkpoint inhibitors and T cells, killer T cells, and NK cells. That's important for this. Again, if these sound unfamiliar, go back, take a quick look at that Immunotherapy Basics. Now, in that, I mentioned that the key, the ignition signal for T cells was a magical system that allows them to see inside of cells. It allows a killer T cell to go around, check on every cell in your body, and make sure that there isn't anything foreign or weird hiding inside of it, like a virus or a mutated protein that comes along with cancer. So how do they do that? This is a system that's used by every single cell in your body. There should be really no exceptions. And it's a way of showing on the surface of every cell in your body exactly what's being made inside. So every time a cell in your body, let's say a skin cell at the end of your pinky finger, every time it makes a protein, there's a chance, a random small chance, that instead of having that protein get folded up to do what it's supposed to do, that cell will just chop it up into little pieces and take those pieces and load them into another protein that gets put on the surface. The peptide chunk of a protein is representative of everything that gets made inside of the cell. Most of it's going to be normal, but if you've got a virus or a mutated protein in there, some of the little bits, some of the peptides, what I'm going to call hot dogs, you'll see why, will be representative of those foreign things. So what happens with those little hot dogs? I said they were put inside of another protein for display. That protein is called MHC-I, Major Histocompatibility Complex 1. It's also one of the things that determines whether you can receive particular transplants, because mismatches from one person to another are really bad. So think of that as like a hot dog bun. It's open, it's got a ridge on either side, and a little divot down the middle, and that's where your hot dog, that peptide, those bits of every protein made inside of the cell go. You've got a hot dog in the bun, and it gets put on the surface of every cell. And that allows your killer T cells to come by, and they will check and they will sample all of these different MHC-1s all over the surface of a cell. And each killer T cell is specific for one particular hot dog. They like one kind of hot dog. It may not be a generic one. It may be the garlic one. It may be ghost pepper variety, but they are particular for one specific foreign thing. All the killer T cells that could react to normal bits of you have been killed off. So it leaves all the other ones that could respond to foreign things, including mutated versions of your own proteins. They're coming along, they're checking out MHC-1, and if they see something that's a match for what they recognize, that's foreign, that's their ignition signal. Now, hopefully there's some inflammation nearby, hopefully the brakes haven't been put on this process, and those killer T cells can immediately attack and get rid of that virus-infected cell or cancer cell. And this happens the vast majority of the time. People think of cancer as something that happens rarely. Cancer happens all the time. Cancer cells are showing up in your body all the time, and virtually all of the time, they can't escape your immune system and they're killed like that. And you never even know that they're there. So for a cancer to develop, for it to get big enough to be seen, to be diagnosed, it has to have found a way to evade your immune system. There's a bunch of different ways cancers evade the immune system. Sometimes they send out signals that repel immune system cells. Sometimes they put signals on their surface, we'll come back to this, that tell the immune system cells to kill themselves. Sometimes what cancers do is they will actually shut down that process of loading hot dogs into the hot dog buns and putting them on the surface. If they do that, those tumors are called MHC non-expressors, or major histocompatibility non-expressors, MHC-1 low tumors. If that's the case, there's no MHC-1 there, there's no hot dogs there, the T cells can't see inside, they can't do anything. No ignition, no killer T cell activity, they're just gone. They're there, but they can't do anything. That's required for them to work. Now, your immune system isn't stupid, and we have faced all sorts of viral and cancer threats for a long time. Our bodies have adapted, our immune systems have adapted. And so there is, predictably, a way that your immune system sees this kind of hiding strategy that cancer uses. If your cancer stops putting hot dogs in buns, stops making the buns, they're just gone, stops displaying that on its surface, T cells can't do anything, but every cell in your body is supposed to have that on the surface. And that is actually, that hot dog in a bun is actually an off signal for natural killer cells. Natural killer cells are called that because they are primed to kill. They are pretty much always on, and they have to have brakes put on them to keep them from killing everything. Their brakes are the hot dog in the hot dog bun. So if a cancer stops expressing that to hide itself from T cells, it then makes itself a target to NK cells. But just like all the other parts of your immune system, there are multiple signals that are needed for NK cells to do what they do best and to kill. And so just having the lack of the hot dog in the bun, just having the lack of the MHC-1 complex on the tumor surface isn't quite enough to cause killing. There are other things that have to go along with that. And so that is where Anktiva comes in. Anktiva is an interleukin-15-like molecule. That is a stimulus. It's a gas pedal, a secondary activator for natural killer cells. It makes them more aggressive. It makes them increase in number. If they see a tumor cell that doesn't express MHC-1, then along with Anktiva, it has everything it needs to kill that tumor cell. Now, that's fantastic. That is really fantastic because a large fraction of tumors do this. But for all of you who are saying it's been proven to work in cancer, there's a problem. It's going to work beautifully, powerfully for some cancers. Not all cancers, because not all cancers do this. It's a pick and choose. Either the tumor expresses MHC-1 and it could be a target for killer T cells, or it doesn't express MHC-1 and it's a target for natural killer cells, and probably Anktiva. You don't pick and choose, it's one or the other, and it would be good to have a test that told you which one it was before you go down a road of trying to do a T cell therapy when it can't possibly work, or trying to do Anktiva for NK cells when it can't possibly work. We'll come back to that. Not every cancer stops expressing MHC-1. there's a range. It's not even predictable within a particular kind of cancer. As I mentioned in the last one, the immunotherapy basics, again, 43% of melanomas have shut off MHC-I. 43% of melanomas are fantastic candidates for NK cells and lousy candidates for T cells. But that also means the opposite is true. What's that? 57% of all melanomas are great targets for T cells and not targets for NK cells. In those cases, you can give Anktiva all day, every day, and it's really not going to do a whole heck of a lot because you're stimulating NK cells which can't possibly attack the tumor because it's still got MHC-I, which turns off the NK cells. You can step on the gas all you want. If the engine gets turned off, you're done. Similarly, 74% of colorectal cancers have turned off MHC-I. They would be good targets for Anktiva. Great. Cervical cancer, great option. About 90% of cervical cancers have turned off the MHC-I pathway and are much better targets for NK cells than T cells. Great. Lung cancer, it's only about 40%. Why is ImmunityBio pushing clinical trials for lung cancer first, even though it's a fairly low proportion that it'll be effective with? Just because lung cancer is such a huge population that even if they only hit 40% of it, it'll still look really good, it'll still generate a lot of buzz, and they'll still sell an awful lot of drug. They'll make a ton of money, just because there's so much of that. Cervical cancer, much smaller numbers, but actually a much better fit. Merkel cell carcinoma, that's a really good one. Again, 84% of Merkel cell carcinomas have downregulated or eliminated MHC-I, and that makes them good targets for NK cells. But again, in none of these is it 100%. You can't say that in Merkel cell carcinoma, Anktiva will always be of benefit because there's still the 16% that have MHC-I and NK cells don't work for. You can give Anktiva all day long and ramp up NK cells. For those 16%, it will never do anything. This is important to recognize. Now, we should be able to test for this. It's actually very easy to take a sample and stain for whether there's major histocompatibility complex 1, MHC-I, in the tumor and see whether NK cells or T cells would be the best approach. But while we use those tests regularly in the lab, ImmunityBio didn't push anything forward with a companion diagnostic, and nothing is on the market as a validated diagnostic test. So there's really no way to tell at this point. The diagnostic protocol is you give the drug and see if it gets a response. That's an expensive way to go. I'd much rather spend $500 getting one of my biopsy samples tested to see if it's going to work, rather than spend $1.3 million to try a drug that, if it works, great, but if it doesn't work, doesn't do anything at all. Okay. The other piece to this that I really want to bring out is that Anktiva is being pushed as not only a replacement for chemotherapy, but also better in every way and superior to the other immunotherapies, including immune checkpoint inhibitors. Now, something I want to make sure that you all are aware of, this immune checkpoint system, the PD-1, PD-L1 blockade that shuts off immune system cells when they find the tumor, actually puts on the emergency brake, locks it down, keeps them from doing anything, actually makes them kill themselves. It's a death signal for the cells of your immune system. This is not just present on killer T cells. This is present under many circumstances on NK cells. And so this idea of being able to get rid of other immunotherapies and just take Anktiva is absolutely false. It actually turns out that in many cases, the responses that are being seen with immune checkpoint inhibitors are not from making it easier for T cells to react. Studies have gone back, taken a look at the tumors before the treatment, and found that they were MHC-I negative, and what the immune checkpoint inhibitors are doing is actually taking the brakes off of NK cells. This happens with NK cells as well as T cells. It is very possible that to get the full benefit out of Anktiva, it's going to have to be given with an immune checkpoint inhibitor, like Opdivo, like Keytruda, like any of the other PD-1, PD-L1 blockers, because that same emergency brake system is not just on killer T cells, it's also on NK cells. Now, it's not always there. but it shows up once the NK cells are activated. So actually, once you give Anktiva, you have much more of a need for immune checkpoint inhibitors. All right, the other drug interference I want to talk about is very important, and that's with glucocorticoids, glucocorticoid hormones. Why do I mention those? Two reasons. Number one, those are generated by the stress response. You get stressed, your body is flooded with glucocorticoid hormones, and what do those do? They protect your cancer. They spike your blood sugar, which feeds your cancer. They actually shut off your immune system and hamper its ability to find and kill your cancer. All of this favors your cancer and not you. This stress response is critically important. Go see our episode about that. Critically important to manage so that you have the best treatment possible. Stress and glucocorticoids feed and protect your tumor. They hurt you. Especially during treatment, you want to minimize stress, minimize glucocorticoid hormones. Please, talk to us, find other ways, find whatever tools you need to manage your stress level. Now, again, the way that your immune system gets shut down by glucocorticoids is by this PD-1, PD-L1 system for which we have immune checkpoint inhibitors. Okay, you could do that, or you could learn how to manage your stress. We'll come back to that. The other piece to this, part number 2, is prednisone. Prednisone is a glucocorticoid hormone. It is given commonly by doctors, by oncologists, to manage symptoms from chemo, from radiation, and from immune checkpoint inhibitors. If you take an immune checkpoint inhibitor and it goes awry and it goes overactive, your immune system becomes overactive and they need to tamp it down, they give you glucocorticoids. How does that work? Again, the glucocorticoids turn up PD-1 expression on killer T cells and NK cells and then have those die when they contact the tumor. So your entire immune system starts to shut back down again. This is, again, not in your favor. If you have to take prednisone to manage severe symptoms, you have to. That's it. That's fine. Just know that if there's any way that you can avoid it, you should, because taking prednisone, again, helps your cancer and hurts you. In the setting of cancer treatment, prednisone helps your cancer and it hurts you. Anytime you can avoid taking prednisone and muddle through with some other option, it's to your benefit. Okay. You can avoid taking prednisone and learn how to manage your stress to keep those low, or you can take a very expensive immune checkpoint inhibitor drug to do the same thing. Or, you could do both. Doing both is actually in your benefit. If insurance will pay for it, do both. All right, so switching gears and wrapping things up, really, again, I want to bring to you is not that Anktiva is good or bad, or that immune checkpoint inhibitor drugs are good or bad, or really any of these immunotherapies are good or bad as blanket statements, because those are false. Blanket statements about any of these things are false. Why? Anktiva is really good for what it's good for. It's an immune system stimulating hormone that works especially on NK cells. If you have something that can be treated with NK cells, it's low in MHC-I, then Anktiva makes a lot of sense. It's very good for what it's good for. It is useless for the things that it's not good for. If your tumor has MHC-I, you can give all the Anktiva in the world and it's not going to do a darn thing because your NK cells can't attack it. Anktiva is very good where it's good, and it's useless where it's useless. And that depends on your tumor. There's no way to tell except by looking at your tumor. We'll come back to that. The exact same thing goes with any other immunotherapy. Let's talk about T-cell engagers or CAR T cells. When those are good, they're excellent. They often give complete cures. So do immune checkpoint inhibitors. When they are good, the things that they are good for, they are really good for. The things that they are not good for, they do nothing. Now, again, what sets immune checkpoint inhibitors, PD-1, PD-L1 antibodies, apart from Anktiva currently is that we have a test, we have a diagnostic companion test to tell whether your tumors express PD-L1 and therefore whether immune checkpoint inhibition would be probably useful for you. We don't have a test like that for Anktiva. We don't have a test like that for NK cells. We don't have a test for that for MHC-I expression on a tumor. We should. And so right now, I'm looking at you, ImmunityBio, and Patrick Soon-Shiong. There needs to be a companion diagnostic so that people can tell whether these drugs are going to be useful to them without spending huge amounts of money and wasting a large amount of time. It takes time, and you have to make a choice between these different drugs. Insurers aren't going to pay for everything all at once. And even if they could, you don't want the side effects from everything all at once. There needs to be a companion diagnostic to tell whether someone's tumor, whether an individual patient's tumor is MHC-I positive or not, to be able to guide whether they should use a T-cell-based immunotherapy or an NK cell-based immunotherapy to actually know which road to take. This is a simple and straightforward thing. We have good lab tests for this. It should be fairly trivial to move one of those into a companion diagnostic setting to validate it and get it FDA approved. Please, if ImmunityBio is not going to do it, someone else do this. Someone get that diagnostic companion test out there so that we can tell which pathway is going to be most beneficial for an individual patient's tumor. Because right now it's just guesswork, and that doesn't benefit anyone. Doesn't benefit patients, pharma companies, insurers, doesn't benefit anyone. Please, let's fix this for everyone. Thank you. Beyond these videos, if you need more personalized guidance or a deeper dive into specific treatments to have your treatment be as effective as possible, I offer one-on-one sessions and medical advocacy. I'm also in the process of developing an exclusive video series that breaks down each cancer treatment and drug in detail, along with interferences to avoid and ways to optimize for the ideal results. You can find information on both of these resources on our website, which is linked down below. Again, if you found this video informative, please give it a thumbs up, click the notification bell, and subscribe to our channel for more science-based cancer insights.